I'm Dr. Victoria, and this is George.
Today, we are going to talk about alcohol use disorder. For the past several months, George has been cooped up inside and feeling quite miserable indeed. Instead of exercising or calling his family members, he has been turning to alcohol to help him cope. Alcohol is a depressant and decreases his heart rate, blood pressure, and his wakefulness. As his body gets used to him drinking alcohol at a particular time each day, it begins to compensate for the depressive actions of alcohol, whether George is drinking or not. This is why people experience the symptoms of withdrawal: anxiety, irritability, fatigue, tremors, palpitations, clammy skin, dilated pupils, sweating, headache, poor sleep, vomiting, and seizures. As well, tolerance builds up with repeated use. Individuals will have a decreased response so that they will need a greater dose of alcohol to achieve the original response. The blood alcohol content depends on several factors: how much blood volume a person has and the amount of alcohol consumed. As well, there are situational factors to take into account. Are there any medications in the body? How prepared is the body to be drinking alcohol? Is the individual also eating and drinking other fluids? There's a reason why fatty hors d'oeuvres are given first at weddings. There are two neurotransmitters at play when someone drinks alcohol: glutamate and GABA. Gamma-aminobutyric acid has inhibitory effects on tone functioning in the brain. Alcohol use results in insensitivity to GABA, something that would normally result in lethargy. Glutamate is an excitatory amino acid, and it is blocked by alcohol. So the body adapts by increasing the number of glutamate receptors so that a normal state can be maintained. To stop alcohol suddenly will result in excess excitation. There are two very dangerous components to alcohol use: in the use and withdrawal. In the acute setting, where an individual overdoses on alcohol, this leads to cardiovascular and respiratory depression, where individuals can have decreased levels of consciousness and even stop breathing. Recall that inhibitory GABA? Of course, there is risky behaviors that an individual engages in secondary to intoxication. As well, the other significant cause for concern is during the withdrawal symptoms, in particular seizures. For the first 2 to 3 days after stopping drinking, an individual may have seizures. People can die from the seizures. While the other periods of withdrawal are uncomfortable, they won't lead to death, even if it feels like it. Delirium tremens is characterized by elevated fever, agitation, visual hallucinations, tactile hallucinations, disorientation, elevated blood pressure, heart rate, and sweating. Those at risk include those with sustained drinking, a history of withdrawal seizures, a history of delirium tremens, more than 30 years of age, presence of a concurrent illness, they've had a significant withdrawal with an elevated blood alcohol concentration in the past, or if it has been a longer period since the last drink. When we evaluate someone in their drinking habits, perhaps starting in the outpatient setting, we will start with our CAGE questionnaire. Do you feel like you need to cut down on your drinking? Do you ever feel annoyed when someone questions you about your drinking? Do you ever feel guilty about drinking? Do you feel like you need a drink first thing in the morning, an eye-opener to calm your nerves or get rid of a hangover? Generally, a positive response to 2 or more criteria should make us think that there could be a problem with alcohol use. To diagnose, there are several criteria to evaluate. 2 to 3 of the following criteria would suggest mild alcohol abuse. 4 to 5 would suggest moderate, and more than 6 would suggest severe alcohol abuse. If the individual drinks more alcohol than intended, are unable to cut down, the use of alcohol takes up lots of time in the day, the individual has cravings to use alcohol, the use is affecting the individual's responsibilities, continued use, even if it causes interpersonal problems, giving up important activities to use alcohol, the use of alcohol in physically dangerous situations, operating a water vehicle comes to mind. Use of alcohol even if there is worsening of psychiatric problems, becoming tolerant to alcohol, and feeling withdrawal symptoms when alcohol use is stopped. In terms of the differential diagnoses, there are other conditions we want to be aware of and rule out, especially in acute emergent situations. Meningitis, trauma, in particular, intracranial hemorrhage, metabolic changes, overdose of a different substance, hepatic failure, and gastrointestinal bleeds. Side effects of alcohol use are varied. At the heart, there can be dilated cardiomyopathy. At the pancreas, there can be inflammation. The liver can progress from a healthy liver to having steatosis, to having steatohepatitis, and finally, fibrosis and cirrhosis. The lack of vitamin absorption resulting from a poor diet when using alcohol. Thiamine deficiency result in Wernicke-Korsakoff, where there is vision changes, ataxia, impaired memory, and also concerning is alcohol use as a risk factor for cancer of the mouth, esophagus, throat, liver, and breast. When we want to treat alcohol abuse, there are several settings this can be done in. Some patients prefer to be treated in the outpatient setting. Others will need admission to the hospital where more intensive psychiatric care and support can be provided. As well, the risky side effects of withdrawal seizures will be better monitored in this setting. No matter where the patient is treated, there are some interventions that will be helpful. Individual and group therapy using motivational interviewing for exploring why someone will want to stop using alcohol and look at specific barriers to treatment. Cognitive behavioral therapy, where individuals can learn about withdrawal and explore their thoughts, feelings, and behaviors associated with alcohol abuse. As well, having peer support is helpful in providing accountability and commitment to treatment. In the outpatient setting with a compliant patient who is motivated to stop drinking and reluctant to be admitted to an inpatient care setting, there are several things we can do. Since we are concerned about withdrawal symptoms, they should gradually cut back on their alcohol use. Setting clear goals will be helpful, whether this is using a smaller glass, purchasing less alcohol, as well as pharmacological interventions. Naltrexone should help to decrease cravings. We start with an oral dose. This can be increased or switched to a long-acting injectable. The injectable is given monthly and can help with better adherence and a steadier drug level in the body. Alternatives to naltrexone include acamprosate, disulfiram, or topiramate. As well, we may want to look into vitamin B12 and folate levels, as well as their liver function with a CMP. If there are any other barriers such as depression or anxiety contributing to the patient's drinking, they should be addressed as well. Encouraging the patient to get involved with an AA group and psychiatry will be very important also. In the inpatient setting, we will want to start benzodiazepines for psychomotor agitation and prevent progression to severe withdrawal. We give benzodiazepines anytime there is seizure or delirium tremens. It is important to have IV access anytime we suspect severe withdrawal. Sometimes, when we suspect a patient will enter withdrawal seizures, we can front load with medications. Usually, long-acting benzodiazepines are preferred, such as chlordiazepoxide and diazepam. This can be helpful in patients who are perhaps a bit older or have comorbidities, where it would be dangerous if they entered delirium tremens and had seizures. Supportive treatment will include IV fluids, nutritional supplementation, and regular clinical reassessments, including vitals. If there is delirium tremens, restraints may be necessary. The goal is to have chemical sedation kicking in before the use of restraints, as this can lead to an increase in temperature, rhabdomyolysis, and physical injury. We may start sedation medication such as a Precedex strip. And again, we want to be cautious and monitor thiamine and glucose levels for Wernicke encephalopathy. An alternative to front-loading treatment is symptom-triggered therapy. Regular systematic assessment, including the Clinical Institute Withdrawal Assessment for Alcohol Scale, CIWA, or similar assessments, will help us to evaluate A score of 8 or greater on CWA would suggest we may need to give additional medication, whether this is diazepam, lorazepam, or even oral chlordiazepoxide. When there is severe alcohol withdrawal that may require tracheal intubation and mechanical ventilation, we may use the Richmond Agitation Sedation Scale, RASS, to help us manage these patients. Some patients may need admission to the ICU, in particular, our older patients, as they may not tolerate the stress of major withdrawal symptoms. If we are unsure of how we can best care for our patients, we can consult toxicology or even regional poison control centers. Now, George has a decision to make whether he would like to slowly cut back on his drinking and remain in the outpatient setting or just get admitted to a facility where he can be monitored and quit drinking cold turkey. He can be proud of himself for making the decision to stop drinking, and his liver thanks him for it. Thank you for joining us today, my healthcare team. Our patients struggling with alcohol use really do need the whole team on board to see them through. Bye-bye.